Thank you, Dr. Strosahl, for coming and talking today. Would you be okay introducing yourself for everybody?
Yeah, my name is Kirk Strosahl. I'm a clinical psychologist and work as a behavioral health consultant at Central Washington Family Medicine.
Okay.
Yeah.
So and it's no secret, you've kind of dedicated the majority of your kind of work life and published a lot of different things on the primary care behavioral health model and primary care just in general. Was there a reason for that, or was there something that really called you to primary care? What was the background on that?
Just thinking back to when we first started in the mid-'80s, there was a lot of research coming out about the impact of mental disorders and addictions in primary care systems across the world. And what was really striking was the prevalence of these problems. So even at the system I was working at the time, group health, some of the seminal studies were done in group health clinics, and these are pretty high functioning people who have jobs, who have employer-sponsored insurance, and yet pretty consistently every time a study was done in the waiting room, 50% of the people would test positive for anxiety or depression. And I think everybody at the time was kind of shocked at those findings, but it just seemed, to be reflective of what was going on in the culture at the time. So at the same time, it was pretty obvious that we didn't have any meaningful way to introduce behavioral health services to these people. And later in that decade, the 80s, there was a follow-up research showing that these people with, who were symptomatic, unhappy, distressed, or stressed, were doubling up every year on their medical service use. So they're really expensive to leave untreated. So like most models, like the PCBH model, we didn't really know exactly what we would do, but we figured that we had to get into that setting and somehow begin to adapt to the culture and to kind of do things the way the primary care providers did. And most of what's in the PCBH model is kind of a reflection of that evolution over time. It wasn't like we knew this ahead of time. It was sort of trial and error. Yeah. Patty and I and the other people that went into primary care with us, we were meeting every week trying to figure out what was working, what wasn't working. So I think the thing that got us in there, I get points.
Yeah. It's good reinforcement right now for the.
This is interesting.
Yeah. Yeah. Well, do you need to check it?
No, I'll check it later.
Let me ask you this, because
9 handoffs.
Yeah.
That's good. Do you count?
Yeah. That's,
yeah, I think there was 9.
Yeah.
Just make sure.
Yeah. Just made though, and I think that's something that's really unique about PCBH is that it wasn't necessarily taking. I mean, it was a big part was taking behavioral health into primary care, but it was more changing how we do behavioral health or changing how we do mental health for that. I mean, when was that was there a moment where it's like, we're just approaching this all wrong, that we got to start kind of mirroring what primary care providers do?
Early on when we went into primary care, Patty went into one clinic, I went into another one. And we graciously were given rooms right in the exam room area because they weren't really built to have counseling space.
Okay.
So we were starting to just see the difference in flow and speed between what the primary care teams were doing, the doctors, the mid-levels, and then what we were doing. It was just so obvious that you'd have to be brain dead not to see it. And then, there would be little comments made by the members of the staff about, gee, it seemed like you were with that person for a long time. What were you guys doing in there?
Okay.
My doctors in my clinic, as we became better friends, they would just sort of kid me about it. Like you waving crystals in there, you guys chanting, I haven't had an hour to talk to somebody and all day in a practice, you know.
Mm.
So a lot of that was just prodding, coaching, encouraging, a lot of it coming from the doctors who got behind the idea, but they could kind of see that this was still kind of incompatible with the way they did business.
Okay.
So again, people try to understand or build history like somebody came up with this idea all at once, and really it was more of an iteration. We just kept iterating and iterating, and you know, the model is still being iterated today, not so much by us, by other people. We're just trying to adapt to what's happening in healthcare and kind of trying to see how we can build ourselves into that equation.
Now, obviously, I mean, you've had many contributions to psychology. The other major one that probably people are familiar with is acceptance commitment therapy. Now, is there any connection that you have with ACT and PCBH? Is there anything of how those two kind of intertwine, or do you see them kind of more separate kind of accomplishments? How do you see those two?
For me, ACT was always sort of inextricably linked to my experiences in primary care, partly because we saw everything under the sun. And what was striking was, you know, outside the area of mental health issues and addictions, you just start seeing suffering in all different kinds of forms. So people aren't managing their health well because of avoidance. They're not taking care of a chronic disease. I never had really seen chronic pain patients in the mental health clinic I worked in. And then I saw a SCAD of them when I came into primary care, where it was very clear that there are some central mechanisms here that are going on for everybody. And it isn't defined by what the category that they're in. They're things that sweep across the human landscape, and that to be effective in primary care, certainly I developed this ability to kind of see people from that more transdiagnostic, process-oriented perspective. And that in fact was sort of what, you know, is distinctive about ACT at one level. Is that it really simplifies this question of what do you do when you see all these different kinds of suffering and you have limited time, and how do you explain this to patients who are clueless about what's happening to them? They don't really have their minds around what's going on, they're just reacting. And so I just found that this is a really cool way to approach people and to talk in real common sense lay terms about things like acceptance or values or being mindful, being intentional, you know, approaching versus avoiding things. To me, those are inextricably linked to being effective in brief intervention models where you don't have much time to talk to people, and it's also in the heart blood of the ACT model.